Oh, no, I didn't have a case.
Oh, you didn't.
I didn't have a case on that. Sorry.
Oh, that's the reason. Yeah, we don't have a case. Right.
Yeah. Almost 3 years of steps.
Really? Yeah, just, right on the screen. Or I just take it over. Take this cover off.
Hey, Tim.
It was a pass ask.
So, yeah.
I saw you sick. That was good fun.
I had 5. I'm willing to give up. Yeah. I had it for such a long time. Hi, I'm here.
Good.
Something stupid. Yeah, so I went and bought a motorcycle on Calgary and rode it down as many dirt roads as possible, which took me a long time. Where are you going now? I get everything. No, wow, here thing. My bucket list leaks. Well, it was short back. If anything should go in it, I better. That one is long. Final here. We threw a text out of town today saying. So they're coming. Right away, instead of live, we became for a lot. And last week, today. So no, I would let you know So, hey, listen, I want to get on that. It's part of yeah, that looks like it's working. You're good. So that's what everybody sees. They see a picture and they see that you're sharing that screen.
Okay, so I'm in the right spot.
Yeah.
All right.
Go through this.
That's what I'm not seeing. That's what I'm wondering.
Where's the mouse?
Right here.
They should be able to go over here and go.
Yeah, slide chair right there.
Yeah, he should be on sideshow.
I thought it was, but that's I'm wondering why this isn't. Good job.
So where's the screen? Up.
Hey, Leah.
See everyone.
Right. Oh, there I am. I'm on the right. Ah.
Where am I?
Hi, Leo. Hi, Jen.
Hi. How's it going?
I'm playing.
It was showing the screen,
Yep.
and it's not now. It's just showing back to the Teams view.
Look that again. See what.
Yep. We are figuring this out as we go. Now this. Jim, what do you see? Do you see like the cool iceberg?
Yep. Now I see that. It says Shawn Strash, and then the heading.
How about this? What do you see now?
Same thing. Nothing's changed.
Yeah, that's where we're running into problems here.
Are you in a PowerPoint or a PDF?
Yeah, we're in PowerPoint and we are.
Instead of doing the slideshow, I found it's easier if you do, I think it's called, let me go in right now and I'll tell you what it's called. Slideshow kind of messes me up when I do it.
We're hitting slideshow and it's not going anywhere. So let's gonna.
Yeah, so go out of the slideshow and hit,
Yeah, see, it doesn't move the
I think
slides at all.
if you go into reading view instead of slideshow,
What I need to do is I need to be able to end the show.
just hit escape.
I'm on a PC, which I'm never on a PC. And I'm trying to minimize this window.
Is there an ESC button on this, on the
Yeah,
keyboard?
of course. That doesn't work.
No? Huh.
Let's go do this. Hold on one second. We're gonna stop the share. And then, do you know how to get this so that we're not on maximized window?
I think if you just do reading mode or reading view. instead
Well,
of
we're back into the
slideshow.
Windows area.
Here's the view.
You know how to work Windows at all?
Windows? Yeah.
Just get me to the point where I'm not, everything isn't maximized. Hey, Doug Vang, I need to come and see you about something completely out of this. So, okay, so now move this over to that screen.
Yeah.
It's to the right. Put it right there.
Okay.
Now make it big.
I'm tied in by that. That's supposed to do that on Mac.
Now you guys can see the screen fairly well. Wait, hold on. Hold on. No, we want to come back over here. Come back over here and share screen. So make this bigger. Share screen. Share screen too. Share, bingo. How you guys doing?
Good.
Can you see the screen, the show?
Yeah, if you go to view and then click reading view, I think that's going to be
Like
what
what?
you
View what?
want. View. There's a tab called view.
Yeah, keep going. View what?
Reading view.
View reading view, okay. You see reading view up there? There we go.
Yeah, right there. This is,
All right, there we go. All right, super. You should see the whole slide, right?
yep.
And now if he goes like this, he can see what's up. And now if we do this, you can quasi see the room.
Yeah, we can.
All right,
Yeah, thing.
welcome to in-person, live, virtual, Arizona Free Market Medical Association.
All right, I think we're ready to get started here.
Yeah.
Thanks so much, Dr. Brown, Dr. Hurley, Jen. It's so great to see you. Appreciate you coming tonight.
Good to
Hi, Dr.
see you.
Justin.
So
You and I will talk.
we have a great group here. As Tim and I were just talking, it's not a ton of people, but it is a powerful group. I mean, the people here are people who can really make a difference in healthcare today. So I'm super excited about who's here. Thanks for everybody for coming. We just a quick item of business. You guys probably saw the email. There is a new website for the Arizona Free Market Medical Association, and there is opportunity for you to be featured on that website. So if you want to contact us about who gets on the website and who's represented, then we can talk more about that offline. We're very excited to have our speaker with us, Shawn Strash, who has done a lot of things in healthcare, and he'll tell us more of his story. But I met him first, or I heard him first on stage at the Free Market Medical Association, and just had to get to know him. So I went out to lunch with him, and have been very grateful for what I've been able to learn from him so far. So we have we'll have Shawn speak, and then afterwards we'll have some time for discussion. So welcome, and Shawn.
Appreciate the opportunity to talk to you and tell you a little bit about why I switched gears and do what we're doing right now. It was Kendrick's idea to talk about this, so I'm just going to, and Tim, so I'm going to pass it off to him, but don't meet your expectations, and I'll talk with Kendrick later, okay? Again, thanks a lot. It's been a real journey. It's been incredibly interesting, and I'm really honored and blessed to be doing what we're all doing right now, right? Trying to accomplish and make a change in the space. And as we've all heard Dave Chase from other folks, fix the system that's truly broken, and really get back into why we started in the first place. And how I started in the first place, not to just put earnings to the bottom line of a hospital, but it tended to go that way after many, many years. And I know we're all here for the right reason. That's to bring accessible, affordable healthcare to everybody. And that's the key. So I knew just set front that there was time when I worked in various facilities and various enterprises where I was doing a lot of things that was what was legal. I look back now and go, probably wasn't as being morally acceptable or possibly ethical as I would consider today. And I see companies and organizations still doing the same thing. They're following the rules. The rules really suck, right? So I am right now a VP of InSurge and hospital relations with Redirect Health. That is changing in about a month. I'm going back to becoming a consultant. I was warned beforehand, told me, said, dude, you can't, you got to be a consultant. So back to doing W2. We're still going to bring groups to Redirect. They got a great plan out here to sell them. But yeah, just some other things going on I'm really excited about. So we can talk about that after this if you want to. So down there, all right, Bill? Down here. Okay. All right. Family, that was, you know where that is, right? That's Lahui. So soon to be son-in-law, maybe, right? Dating our youngest daughter, Sophia. She's at A&M. Oldest daughter, Lauren. She's a CO with a pretty large hospital. Yeah, I'm just messing right now. So, Pops, what do you do now? I don't want her to get fired, so I told her this. If we send you a patient, that patient will probably come to your facility and have zero out of pocket. And she goes, that's good. So that's good. And I don't tell her about the dark side. I want her to learn. Spend a decade doing she's doing. HC is a great place to have in hospitals. They're the best. They play by the rules, but so she's ready to come out and do what we do. She'll be prepared. She's already started to ask questions, right? So it's two grandsons, Hudson and Harrison. My wife, Norma Jean, son Gunther, and son-in-law John. All right, so a little bit about myself. Canadian by birth, immigrated to the States in '91, down to San Antonio as a port of entry. I met Norma Jean. My first healthcare job was in the Canadian Coast Guard in search and rescue. Best job I ever had. It was awesome. Started as a rescue swimmer on the Great Lakes and became a boat coxswain, which is a Canadian captain. So I did that for about 5 years. It was awesome. It was paramilitary, you wouldn't be military, but you got to like an EMT on the water. That was kind of what it was, and it was good for great job, loved it. So my first healthcare admin job was with OHIP, the Ontario Health Insurance Plan. You know it?
Yes.
Oh, you are. Where were you? Okay. Awesome. Are you a Leafs fan?
Used to be.
Oh,
Not anymore.
Coyotes. I feel a Leafs fan. They haven't won since Canada's Federation. They do though. They do have the second most number of cups, but Chicago's not going to do it because we haven't won over 14. So OHIP is Ontario Health Insurance Program. Came out of school, but didn't use Ottawa. Masters up there, and then they asked me to take a look at the number of ERs in Ottawa and to determine if we close down one or two emergency rooms. There are 5 main hospitals in Ottawa. There's probably a ratio. If you've got one hospital in Canada, there'll be 4 hospitals here. It's a much higher ratio that's the population down here in Canada. So, but still, I want to see money. Said, take a look at the number of ERs in Ottawa. Fresh out of school, I'm going home. This would be great. And they said, if we close down an ER or 2, how much money would we save? And what would that mean for the care of our constituents, and how we die and how we die? And so it's I do this. Backed up, moved down to San Antonio, did a 1-year MBA, and was able to work. That's my wife, there. She's in the back. But so after that, started out on my career, and that was essentially turnarounds and startups. It's been a blast. So first startup was an imaging center in San Antonio. I started sales first. My dad said do sales first, and then talk to people, learning, and then got operations. So right around when Start One came around, when this allowed, like you said, no more sort of third-party investment service centers. They said, hey, everyone's left, no more referrals. Can you fix it? And so I recall, working long hours that you all know about, and literally being out there on the weekends, with the sweeper on the parking lot, painting the stretcher cells and all kind of stuff, trying to get it back going, which we did, we turned it around. So based on that, the owners, they were from Israel, of all places, and they owned all the equipment, went for Chapter 11 an organization that was successful. We saved it, and I got a call from the hospital to open up. I was told it was the 3rd physician hospital in the country. So it was a ground up in Austin, still there. And we syndicated that and did okay. Got a call. We got a call from a physician in Georgetown. Said, hey, can we come and do a presentation about living in Austin and tell us how it's going to work for us? So did that and got a call from HCA to have lunch, and it was on the campus of their hospital, so they didn't like that very much. And a lady named Carla Holden interviewed me in Mobile in Dallas, corporate office. Did 3 or 4 years of mergers and acquisitions with the surgery division, and always wanted to be in the hospital side, so school, and really wanted to help people get the hospital, make some money, right? But really spread the good word and get folks to care and all that good stuff. So became a COO with HCA hospitals and then who was formerly the CEO of Vision, called, who was married to Carla, so it all fits. Said, hey, Rolling Hospital, Alaska, would you think about moving up to Alaska? And so it's a story, it's a true story, that I got a call from Chris, and he didn't really ask if I wanted to go to Alaska. He asked about Jean, what she would think about it. And I said, how long is it? It's a 2-year deal, get up there with it, and then come back. We did that. What's ironic about that hospital, it was called Matsu Regional Medical Center. 75 at a hospital we closed, a hospital in Palmer, Alaska. So Palmer and Wasilla are about an hour and a half east of Anchorage. If you get up there. So the hospital we placed right where Highway 3 split, we put the hospital right there. So it's a beautiful location, super nice, probably the nicest hospital I've ever been. It's gorgeous, all rock. This couldn't sound bad. We had a patient who couldn't afford to pay his bill, and he was sculptures in silver. He had really nice silver sculptures in the hospital to pay his bill. I know. He wanted the dentured service. Yes. But that little hospital had 65% of charges, very 1980s style of reimbursement. Whereas down here, even Banner gets about overcharged 23-24%. Margin is the top line on a 27 average unit census, 27 patient a day. That hospital put down between $200 and $300 a month. Now it's between $400 and $500. It's ridiculous. So that's right, making bottom line for the company. So we were returning from Hawaii from a vacation. And I got the tarmac, and we were going. It was part of TRIAC. Or trying to spin off of HCA. HCA had a big OIG investigation. It's called Columbia in the late 90s. I was there for that. I just was back there. The company for a year and a half. The OIG comes in and says, you guys are going wrong. People got arrested, right? I remember flying down to Tampa, the meeting with a guy named Bill Hussey. Bill Hussey all comes around. He was the market president for Tampa with HCA. And I called, said, don't come in. I said, why? There was a bunch of guys with blue suits and trailers in the back, and they're taking everything. It was the FBI down to all the stuff on the office. So that happened, and a year and a half in M&A, we had a dozen people in our department. By the time we were done, we had 3 left because they said no more acquisition. We had a cool offer on. That was really interesting time to see how Columbia became really what. Right? So Dr. Frisch came back in. Scott was gone, and the culture did. There was some pretty. There was a lot of risk taking. I remember when before it got rated, out of state was different company until after the fact. And HCA is really the company after that. Under the corporate integrity group, they had 5 years CIA, and the OIG said you were going to write a compliance program for hospitals and make it public. That compliance program is now the base of every compliance program in this country. Every system uses it. It was really in depth and very fundamental to compliance. Anyway, back to the lower 48, just about 2 years. And how that happened was we landed on the tarmac in Anchorage. Chris Holden called, turned the phone on, and said, "Dude, bad news." We called. We were going private. CHS bought it. It's literally in the 11th hour. I have no love lost for my company right now. They area even today. The president of the company I support you. I like to say his name, but yeah, not a good dude. So went to Tucson, Oro Valley, ran the Oro Valley Hospital 4.5 years. We kind of like, I really love to work with my physicians. And 4.5 years, we had 1 hospice turnover. Had the best team, 1 turnover. That was it. That was purposeful. Fantastic team. And the hospital-based physicians, and then the hospital go and follow up with the referral sources, and this patient care was absolutely amazing. That's of course, best of interest, right? But came here to PV. They needed some help, so we did that. And then Chris Holden called again and said, come to Amsterdam and his SVP with us there. And our line was, we do more scopes than Canada. That was the truth. Scopes than Canada. And so the good and bad as SVP, your column is published in the annual 10K, which can be good and can be bad, depending on how many family people call it. But anyway, I said that though, because probably at that point in time in my career, we all say this money on everything, was making the most, but wasn't happy. It didn't like what I was doing at all. Sitting on a board with a public traded company, and Chris is really smart. He's a really good deal guy. He's really brilliant, and he played by the rules. But when we acquired different companies, it was less about the shareholder and definitely not about the patient. It was all about the word comp and senior technology. That's really what it's all about. And it was eye-opener. I didn't think it was like that at all. So it came on me. But I was over 6 divisions. We acquired anesthesia that was in our center. We brought it in-house. That was my doing. And then we also established a hospital ASC joint venture division, which was called it financial engineering. Still, right? Still more. But where we had our ASC, which is independent, so 51% owned by AmSurge and 49% by physicians. We would contact the system that had great rates and sell 26 of the 51 to the hospital system. We would have certain governance rights and certain majority items, I call them privileges, that if there was a 9-member board, it would take 8 members to vote to make it work. So even though the hospital had legal control, they could just take the center, close it down, move it, sell it. But when you're getting paid $675 for scope, see, and you partner with THR in Dallas, and all of a sudden you're getting $2,300 a scope. You sell half your ownership, and maybe 3 times more. You got physicians that own 49%, make it a 3x payday. So that was what we did. Doesn't do it anymore, but at the time it was high fives, and that's what we were there to do, to make money for the company. We bought Sheridan. We went from a $1.3 billion company to a $2 billion company. And that was partly because we realized that bringing anesthesia in-house was a pretty good deal. And then there was a capital event. I left. And then Chris went on to bring the vision to the company. So after that, it was essentially a deal with Arise healthcare system in Boston. We were a single surgical hospital, 3 ASCs. We had 105 significant physician partners, 11 entities, and it was losing $9.8 million. So nothing to lose. Was a free agent, and I met one of the best friends of my life. He was the main controlling partners of Arise. Came in, had a date and a price to meet, and there was some pretty heady days back, working long hours, not sure if we were going to make it. Put a lot of capital in, personal capital, and it was a lot of fun back in retrospect, but really stressful back then. Turned it around. We sold to SCA, which is now owned by Optum and United. SCA's largest acquisition. So that felt good. Did my year with them on the theater. Worked for a corporate. It's away and come and visit you for 2 hours and leave. That part was good, but they come and tell you to do stuff. And I think the guy I reported to was born in a hospital but never ever run one. And so that was interesting. And then I got a call from a company called Landmark. Florida. So we picked up, moved to Landmark. It was 7 hospital long-term acute care hospital company. We were right across from Arthrex. So Ryan would come over and visit every now and then. Our ORs are all Arthrex ORs. They were 600 square feet. People say this, but they were the nicest ORs I've ever seen. They were beautiful. Walk into the main hallway, have CS on this side, ORs, there were 3 of them on one side. Each wall that faced that hallway was 100% glass with drawers you could push stuff through. We had windows the outside of the building that between cases push a button and the blinds went up. It was keeping the rhythm going. 84-inch monitors for the soap monitors. We had the OR lights had, I forget what they're called, I believe they were striker, but they had so many light bulbs in them that moved quickly. So when they shone onto the sterile field, there was no shadow. And then we also had sterile field was projected across fiber optic to the innovation center of our office. And so we had patient science. So they would, my whole claim they had 1,000 circuits of document through, which it's a lot, but that's the plan. We helped to develop their hip and their knee. So we had a couple of docs that basically certain family orthopedic that helped develop the knee. And I learned then, I've probably been 2,000 scrubs in my career, but I had it's totally this part that the speed and efficiency and effectiveness of the implant is really instrumentation. And I remember one of the docs saying, Dr. Zara saying, man, great implant, it was going to suck. And so they had to work on changing that. It was cool experience. So why I know the author of this presentation is why I love the space. So I'm at Landmark and we grew from 7 hospitals to 9, and another turnaround. We had the best earnings in about 6 years. We gave the first raise 3 years, the first ever fall when K match that fall really, really good. So I got to a point where there were three conversations and some contemplation, and a couple of books later. There was one conversation. I was flying back from Georgia, one of our hospitals, and flying back to Florida. And I sat beside a guy that I could drinks. And he said, "What do you do for a living?" I said, "I'm an office." It was me. And we got to a point where essentially he said that I was a used car salesman, but maybe a notch below. Oh yeah. And I said, "Why?" He goes, "Man, I go to the hospital. You guys don't know where I'm going. You're disorganized, costs a fortune, and you guys are still gonna make money." I said, "How this right? Because I wasn't suspecting about how the rest of the story happened off. But it got to a point. Look at that. So second conversation at our daughter's school, the youngest school backpack, and the administrative secretary of the school said, "Hey, Mr. Strash, I was at your hospital, had a surgery, and I have $4,000 out of pocket. I can't pay." She was like, and people around, right? So don't worry about it, we'll take care of it. And she $6 an hour, something like that. And so we took care of that. And then my wife said, "Hey, what's going on? You're miserable, paying a lot, you're and so what's going on is that I'm tired of getting up in the morning and raising prices for the same outcome. And you've heard me say it before, right? Every hospital is a for-profit hospital. Some pay taxes. That's it. End of story. Don't ever want to talk to you. A banner or a tenant, they're in it for the same reason. And so that's what started to grate on my nerves. It's not what I got into it for. And for 25 years, I've always worked and always been, if it's turnarounds, I'd be ahead for 6 weeks before the family came. So you get over 7 days a week. You guys know the question. And that wasn't the part I disliked. Families would come, but why we were doing it, and it's really changed. The exponential focus on the bottom line for hospitals now is so much different when I first got into it. We always wanted to make a dollar, but not at the extent of what we see today. It's horrendous, and then we'll talk about. I don't want to talk about COVID in a second, but how that changed the bottom line as well. So I also read one book, and probably seen it read as well. One of them is Company that Solved Healthcare. Seraphim up in the Midwest, they make decals and things, and they did a great job of saving a bunch of money. I remember talking to I did the thing that Dave Chase, right? So we did Naples, we had about 4,000 employees, we had 380 up in Cost of the Rise. I had a really great book called It Was Brand. I read that book, Company Sold Healthcare, after I brought him in to set us up. This thing, I biggest broker, I knew him. I got a 6% decrease over the previous year. I'm happy. And I read the book, and Brant got a big raise. I have no idea, right? 380 to 4,000 belly buttons, pretty well. And that's cool. But I read that book and said, hey, man, too good to eat. So why can't they reward our employees? We run hospitals for going to a local so it's sort of sky. I can't do that. And then read Dave Chase's book. This was the CEO's Guide. Great book. And actually, Tim Spooner's advisors in that one, right? Tom Hart, guy, smart guy. And too, so did that, spoke to me. Actually was pretty soon after that airplane ride back. So that was when I called him. I remember writing the email on another flight, and he called me. So that's how we got into it. Dave's been and just loving what I'm doing. It's great. There's so much to do. Like back at in Denver, right? 2 years ago, we were talking about DPCs, and now DPCs is not anymore yet. And then this time it was definitely about alternative PBM models and captives. Captive is still applying. I have no idea what's going on. But that's how I made a change in the space and why I did it. It was a moral and just internal insight to what I was doing, and it feels a lot better today. And do I miss the walking through the hallways? And, there's a bit of ego involved for sure. Everyone loves you, right? When you're CEO, everyone loves you. You never hear about that stuff. But it's why you're there and why you're doing it. So I mentioned our oldest daughter, and she's smart, and I'm really proud of what she's doing. And she'll 10, 15 years from now, she'll probably see that light too. But I think I mentioned to you probably that she asked for what I do. And it's, when we bring patients to your hospital, I'm out of pocket. So she thinks that's really cool. I think so too. There is the business office staff that's responsible for collecting personal financial responsibility for patients. The worst job in the world. And then always question in my own mind, people that like to do that, are they doing it for the right reason, to work with the patient, or are they doing it to because I feel like it's our responsibility. You wonder about that. And we had a very set process in place. And that was, it was outpatient surgery. We all know that a surgeon on health in the past, they hit you when you get there, right? It was your out-of-pocket responsibility, or your partner or your spouse or whoever goes with you to home. If you're an inpatient, it was a clock. Second day in the room, clipboard, just sleep. Your spouse, not even handle the that was a conversation. Horrible. Sucks. Which is why we're all here to change that. So if you don't mind, I wanted to go through. I thought it may be interesting to go through a couple of sort of hospice secrets about things that you don't hear about on the outside. And the first one is percentage charges contracts. So every year the C-suite gets together. It's pretty easy. Raise your rate 9.9% every year. And the reason is that 10% was supposed to work with payers that at 10% they review your contract. So we avoided that 9.9% to 9.9%, 7.3 years we doubled the rate of charges. And so we did that because today it's probably 1 in 10 agreements for percentage charges, now probably 1 in 20. But when you had a patient come to the door, the good CFOs were on it, and we had a weekly meeting, and they would report on how many percent charges patients were in the house and how much that meant to the hospital. That was a big deal. We never, it's really shameful, never cared about the out-of-pocket information. We thought it was employer responsibility through their That wasn't our responsibility. That's your responsibility, your patient's responsibility. It's your fault for being employed by that employer. That's terrible. Don't blame us. That was how terrible, right? And now, in terms of the ACA, so the ACA was enacted, CHS bought our company, and I remember when he spent the time on talking to his face, he called every CEO and said, hey, he was conservative, but he wanted all of us to encourage our employees to vote for Obamacare, for Obama, because it was better for them. That was, I think, I didn't do it. And then this is really bad. He would call, he never emailed, but called CEOs end of the third quarter. Tim, I don't know if you're looking at me like hit me or
I'm glad you're on our side now. Thank you for bringing the Enigma machine with you. And is the 9.9% on ChargeMaster or?
You open those up, some charges contracts, then you make bank. I mean, I remember a CFO saying, hey, that patient in the ICU, if we could vent that patient. So. Right, yeah. Now, in the conversation you have with your physicians, right, it was set script. But so yeah, Wayne would call in the third quarter, and it was him, right? He wouldn't have delegated to anyone else that might talk. And so he would call each CEO, and we get a call. Our call was talking about saying, what do you say? So you got this budget for the fourth quarter. If you beat your budget by 10% commission, I will double it. How do you increase commission cost?
Bring the ER people in.
Yeah, talk to your employee ER docs on our reviews. And this is the script. We train so well to know inequality enrollment for admission criteria. And we had, each of us had a system in our office called ProMed. We were told to go down to the ER and say, Mr. Smith's room number 6. He's got chest pain. He's got see the record. He's got an abnormal EKG, and he's got positive troponins. Why has the application not been completed? This is an administrator now. I'm not a doctor. I'm not a doctor, but. And then there'd be a conversation with your, with your ER docs, and say, hey, you guys are aware of this. I'm not a doctor, but and the racks will make it straight anyway. The racks keep it straight in this house. So do you think a patient is on kind of in the gray area? It's up to you, but I mean, so lost skill to make that 10%. I don't think I ever got one. She be a bunch.
Not that you brought home the news.
Oh, I love it. But and it got to a point. I like to think I did a pretty good job at good operations, and really much more an operational CEO than guy. So much so that when we built urgent care, right? It was all this before they became popular. It was all about good paying, well-insured patients in urgent care that future hospital. And I remember the new division president came in, he called me, Strash, got the most transfers of any hospital in my hospital in my division. I said, yeah. So what's up then? Why you transfer patients? I said, oh, I'm not. Transfer to our hospital. Oh, no. So score. And much to the point where we would, I always had my strategy was to employ and bring in primary. We wanted to employ, quite frankly, high data, high cost specialists. I'd rather be independent. We would feed them with our, but we always tracked. This is where I talk about a secret ledger, secret GL. we look back the referrals where they went. You're not allowed for any hospital to combine the value of an employed physician to your hospital. It happens, right? But you can't actually have a report that publishes that. Dr. Johnson, raised bottom or smear, you pay half of it, score. You can't, you're not supposed to do that. Good. And so we would track each and every referral and that 5 rules, 4 or 5. But out of the system because of the family relationship issue. That's what. A quality issue, unacceptable. Out of network, we'll fix that. A current relationship, let's get that, we're going to change that. And then if the patient lives outside the market, that's okay. But we look through every referral, I call it minor list, every time. And the primary care system didn't get it. And when it came up to renewal or that clause agreement, they want it, right? I'm only retired on that. She was really mean. You remember that because you got seen too.
We're higher cost, so I need to refer.
So it was a husband and wife team, and they worked at one of the combiners their clinics, hospital, hospitals. It's just so rude. She had every year about 3 to 4 times turnover in their staff. So 300, not 3 years. And wouldn't take Medicaid, wouldn't take the just slum deals with the best for her. So I had it, and I talked to corporate and said, hey, this is not a okay, we'll try to do it. Went up, gave her, previously she's gone. And it's just, I think we ended up paying her 1 penny. It's because she was what only time. So we all know the story of ACO is another story out of the market. And Aaron was doing the Pioneer ACO back in the day.
Right on the west side. Was it over on the west side of town?
Yeah. So I was with the PD hospital and the Vanguard, and I remember we're sitting in our corporate meeting, and so we're talking about the Pioneer ACO that Banner was doing. So they should have formed it with 606 positions. They could have formed it with 665 positions. They officially formed their first ACO with 666 positions. 666. Could they not have chosen the different number, or was that number intentional? I mean, it was. I didn't say, but we all know ACO are not for better care to keep the revenue in the house. So I thought I did with this, and that is, we open up to questions and anything else guys want to talk about. There's other things like, big drop for monitoring in the ORs, big rip off. The surgeons will tell us, I can't do it, I'm not going to look at the OR. They form an entity, they release the recovery vendor, and then they charge the patient because you have a network $20,000 to $30,000. Crazy stuff. And there's a surgeon back in Austin who we're good friends with.
I think I can get there.
Right, exactly. He's done his job. So, and then pods, right? Additional distributorships. So there's a case I helped Rosetta consultant out a couple of years ago. It was a hospital in Dallas. It was a joint venture of a not-for-tax hospital. And so it was a surcharge contract. You say, hey, help me with this, and looked at it. And there were a few vendors on there that were supplying screws and biologics, and it was a 3-level P-lift, and so there were 3 cages to put on the back, and 3,000, 5,000, and then for 10 cc amount of cement biologic, 18 grand. And so it was Sunday night, and I requested invoices again to the hospital, but also get there on the so 3 different commercial payers that we were looking at. And this is a big system, big amount of system. So Sunday night, I called the phone number on one of the paper invoices. It was called Python or something. It was a stain on it. And 11:30 at night, I looked up the address to some guy's garage at his house. Right?
I don't mistake.
Yeah,
Just.
yeah, there we go. It was 666. And he answered the phone 11:30 Sunday night. And then went to the bill and talked to CFO of the office. Said, it's $7 contract. But it looks like it's using a pod. You can use pods as a fair market value, just not fair market value. Here to help you. I'm not here to hurt you, I'm not gonna make any calls, but you're not gonna charge us $380,000 for 80. 80 grand is too much. It's about 30 too much. So that stuff still goes on. And actually Texas is about 3 times the rate. I thought it was Texas. Talked about a little bit was COVID. So we're Chris Holden is at our house in Naples, and it was March 17th. Because I remember the stock price was $58. March 17th. He was down, his son Riley was becoming a commercial fishing captain. And so Chris Elwood wanted to bring it back home to Tennessee, Nashville. Story boat, trucks, and property. Chris and I friends, but he's sitting in our living room and saying, I don't know, Sam Bates, he goes in that big swing, this big swing. If you see him, good looking guy, tall, slender, full of hair, star, and super smart. Hey, right? But really good.
I know.
So Chris said, yeah, Sam's really worried about the company. That in December they were trading at $290 a share. So now it's 75. I said, no, they're actually 58. So crap. So you're doing okay. Yeah, Sam and I joke around with our sons, what's the put price and us getting fired? And he's past that put price, $58 a share. He's been fired regular times a long time ago. He's worried about the company not surviving. Yeah. Chris would always say, you work for him. I never had to say when I was looking for him back. But if he said something he didn't believe, he said, I'm calling bullshit on that. I never heard of it. And so we're sitting in the room and I said, Chris is calling bullshit on that. And so what do you mean? I said, Sam is super smart, really, really. He's back in Nashville. Exactly just said that this is a worldwide pandemic unless we have seen in our lifetime. They are the largest hospital provider in the world. He's gone back in Nashville where most of the smart folks maybe stay are. And said, guys, gals, this is what's happening. The largest hospital provider in the world. Figure it out. We're going to make that. And they did. 2020, 2021 were the best years in history. They've done incredibly well. In fact, the rumor has it, so April 20, Medicare approved the 17-year COVID rates, which were essentially respiratory codes on steroids. 13 of them, you had to validate or verify the patient had COVID. Or there was no validation necessary. But telling the IRS, and then $1 million, but other than $1,000, I pay $100. You can't. That's all. That's what it is. Kind of get around that too, how that works. And that is the other thing that Medicare said was that so they have a rack on it, and you always consider fluid emissions to be soft emissions because there's no intervention, not communication over fluid. You always look for a good fluid, right? My first CEO said, Alan back in Georgia said, man, I'll try to pull up and drop off fluid emissions, right? To make your budget. You're in this to make money, so that's what you did. But the rack would come in on the soft emissions, fluid emissions, and when the rack doctor
No, stop touching that word.
the appeal that they made with Medicare. So if you have 100 patients,
No. Hold on. Mommy's got to make sure the egg is all stirred in.
they lost all that revenue, right? But the rack made 30% of it. So what Medicare?
It's fine. I can do Indian Thai. I can do a salad if you want to just go to whatever that place is that Carson used to work. Okay, just stir just a little bit.
We hear you, Doctor.
Yeah.
I can't do it.
I'm sorry.
I can taste it.
There, you can do this. Hold on.
By the way, we're not listening to the chat. So if you're chatting,
I'm sorry, I'm so sorry. My kids have been taking the phone. I'm trying to help cook dinner. I apologize so bad, but I'm listening.
mute if you need to there, Leah.
So this is usually a revenue audit contract, really audit all the admissions. And usually it takes 18 months, right, for Medicare to in time and all that good stuff, at least 18 months. Now we have to get this goes very quickly. Just a lot of crap. So it took 2 months for Medicare to approve goes, 17 goes, right? Before did not move legality for 30% increase in reimbursement for patient over our normal respiratory code. And they said on top of that, no rack. Like you don't have to validate, and you can say the patient had. So questions like, and I validated this with someone that works in space, right? So what are your patients at COVID forecast? We have a slide yesterday, 2 days ago, the only one that comes in probably be okay. Let's move this. Oops. Never check. So I love AZ. I think it's the best company ever. Really, I do. Very, very straight in their own out of rules. You know what they're doing? They are really good operators.
That's $216 a share today. It's $216 a share today, not 58.
Oh no. Is it 216 there? Yeah. They had an investment last quarter. What's that? 216.
Yeah.
Yeah. Not bad. Not bad. They're up to 3. Wow. So there was word out there that their friends were in Washington lobbying for this. They have 17 codes. And they're, like I said, they're very, very smart. They do it the right way. They're patient, they're smart. It's a great culture. And like I said, they learn back in the 90s how to do. All right. They still try to out ton of it. But and they're in markets that they can do that. So, but if you go on their website for the code statement, it says that we are the largest hospital company in the country. We have treated more COVID patients than any other provider, both verified and suspected. So they cover their butts. And that's what healthcare is all about these days in terms of facilities and the rules are twisted. And we're still there, right? Still happening today. That's kind of my story. I feel great about what I'm doing. We're doing RDP stuff for various folks. Still doing some vilification. I love doing that stuff. I'm leaving Reader Record. They got a great plan. There's lots of great plans up there. And other people in space we're actually putting out a center in Texas to do send to do all the payments up there. That's in the off records. That's but and do cardiovascular and more service. So that's happening as well. So that's kind of where we're at today.
I have a question. Not very often you get a CEO of a hospital and smart guy. I'm from primary care and sports med, all the fun stuff that goes all around with it. And I personally believe that if the primary care is carved out in the future, that the landscape of healthcare. So the thing that a lot of people don't talk about is the investment that physicians like myself put into my business. So I built an insurance-based model from 0 patients, right, from scratch. Lots of stories that could write a book on, the problems with that. But to 18,000 people. And when Honor Health approached me, when they said that we can't buy, the valuation of the company like EBITDA because they'll go against the investment world rules and laws. As we're going to refer your patients to our labs and imaging and our specialists. But we can give you, assets. Okay. So I said, no, not interested. I mean, their valuation was like $400,000-$500,000. Yeah. Now the question is, by just within the last 6 months of converting into direct primary care, right, selling programs as well as converting to a membership model. Right now, we're bringing in around $200,000 per month. That's 2.4 million a year. So, and I heard through the grapevine that membership models are 10 points higher than just for a cash-based service. So if you have like a membership model, you can get 10 times what your normal practices were. And most primary care doctors don't think that way. So over the course of, say 4 or 5 years, maybe 10 years, gathering 600 members, 1,000 members, what would you say the valuation of a company that's in a membership model grossing 2.4 million a year?
Yeah, so internal earnings definitely going to depend on the quality of the So I look at it this way: if you have a subscription model, it's a definitely you've got more certain revenue streams, so that's going to be worth more money for sure. I mean, honor wanting to pay for assets, right? It's fractional term in the bottom line. It's not even a multiple. If you want to talk to somebody, I know Greg Kingsland, who is the founder of Valley Management Group, and I've known him since 1996. We had 3 employees, got 300 employees now. His former partner, Elliot Jeter, is another company called Weaver, and we can get a phone call and ask questions.
Are you trying to sell it?
No. I deal with the point is,
I was waiting, it doesn't matter. Continue to grow a fundamentally sound business.
the point is that I get scratched my head, like I think that I just increased my value. That membership model, insurance model, by almost 10-fold.
Yeah,
Within 6 months.
Yeah.
And so, and most primary care doctors don't think that. I sat down with a group of primary care doctors at DPC. I'm like, you guys, I understand that you got 300 people or you only got 400 people, but you have value. With the insurance-based model, yeah, you brag because you got 3,000, 4,000, but you had zero value or an investment into yourself. Now you have all this. And so if more primary care doctors would realize that, which they don't,
right.
they would see they have a ton of value. Now, if you take 300, 400, 500 people and you did something kind of like what CrossFit does, which I love what CrossFit does, is you basically put under one umbrella, or you can don't franchising, but you basically sell the rights to just one name. So everybody owns their own clinic, using one particular name, which I'm sure we're primary care to begin with. But there's a lot of value there.
Yeah. And I agree. And the honor saying we can't buy you because of the referral, right? I think that's they can here's their risk. Probably get an evaluation company stats with 1 or 2 plan service. But then they can't be seen going forward. This is they'd rather be able to do what they can to pay you for continual business. So it's a risk for them. And then coming out of the M&A space, when we were buying an AS company or what have you, if they have their focus on out of network, so you know what, I'm not interested. It's too risky for us. It's too volatile. We got various ends of the curve. Some and kind of rates of 9%. So get a network, we'll talk to you. But that provides certainty. So I see what you're saying in terms of the model you're talking about. Cash-based subscription was certain that's about the value. I think a lot of want to sell.
Oh, I don't want to.
Yeah.
I don't. I'm just saying. I just improved my value within 6 months. I'm just like, what? It's just kind of crazy to think about it like that.
Yeah.
But what are that value? But it's the person across the table from who said, let's talk about how your business. And they value on your revenue, walking customer versus annual recurring revenue. Annual recurring revenue is very different model from an overall growth and profitability standpoint than actual month-to-month revenue that's not sure. So there's a whole lot of different financial models that go into it. The issue is taking the road as a TPC doc and a TPC practice in a free market economy, gathering patients that seek you out for your services creates a much more structured and visible value chain than a value that's built on contracts that are uncertain as to the reimbursement based on discount of bill and charges and renegotiations and all sorts of things that happen. And it's a one-time deal from an insurance payer or a third-party administrator that isn't certain. So you end up with a much more solid foundation in a DPC practice because of the annual recurring revenue and the growth that you have. Just from a VC sort of standpoint.
Yeah, I think
Ish.
I do want to know. I do think that it's interesting because the more that I tell the doctors, because I have helped set up 6 already, and I mean, and my other business, the wellness clinic, which we do financially really well there, but that's just selling programs and peptides and weight loss and stuff like that. But that is really it's kind of crazy how much people spend on that kind of stuff. But anyway,
Have you heard of sex?
yeah. Anyway, the whole point is, so I help these people. I mean, you're building it. I don't know. I think the time is right because the demand is high for good physicians, especially the female physicians. In particular, I know that the hospitals buy them up very fast. And I tell them, like, if you set up your own shop within 1 year, you're going to be profitable. Now that you have value and you have assets, now you have an investment. And most primary care doctors just don't think of the long-term investment. I mean, the best 401k for any family doctor is to set up your own practice.
Right.
Period.
Appreciate.
Period. But, and then that's one of my points, because if you took 55 clinics throughout the valley when I was and they blocked me every step of the way to try to hire new physicians, that if you take them all of them away, right, the referral source, like you were saying, goes away.
Yeah. What are the opportunities? We have several specialists that are listening in. What are the opportunities that you see for specialists and surgeons and that in the free market space against all of those things you were describing earlier in your conversation? That,
Right. It's
against the behemoths of the hospitals and the large surgical centers. So how would you consult them to go into practice, and do things on their own in a free market enterprise?
right. So, the rule of insurance companies is critical mass. Right. So it's all about administration of their claims. It's a hassle. If you have an ASC that provides great prices, if you do 100 patients per month, the hassle to provide a contract and to administer a contract is much higher, right? Than an ASC is part of a system doing 10,000. I'd rather have that consistency. What I see is that, just personal opinion, and that is 2 years ago, if you mentioned DPC, there are a lot of folks who wouldn't know what it is. And we're getting there now. I see also the bundle surgeries coming on. So bypassing the insurance companies, going direct to the employer, TPA, Coral, Sano, everyone else, big reputation, but Coral's awesome. They have a voucher program where they, you have a set case amount, you data curate that patient experience, and then after that patient experience with 7 days, they pay you. That's a pretty good deal. Is it at a point yet where we could stand up 100 practice units? Probably not right now. But I don't know, 3 to 5 years what that means. And you see things like Swiss Canada, but I met with Banner folks, and Banner Atlas right now has 23 ASCs. Their budget is to have 55 in Phoenix. Their budget is to have 55 ASCs by the end of 2024. That's a huge, right? That's a huge figure. And so they're doing that by buying up small independent ASCs. Payne is having a difficult time right now. Patients are out of network, and the payers don't want to pay for them. So Banner for those are small, which is good. It's not helping the question you have. But I think the alternative payment models is where we got to go. It's tough. There's fewer independents now than there ever was before. I think you get to a point, right, where the pendulum swings one way. And if there was 10 of us 2 years ago, and unfortunately it's only 3 of us left, 3 would be pretty wrong. And it's all about the patient experience. Yeah, we haven't been working harder. While doing it, we're all
There's a thing called proms, right? Age reported outcome measures. Yeah, and they,
part of the Pepper reports.
I think so.
Yep.
But what's really important is that when you look at these reported outcome measures, that they have that you can really start data collecting with the phenotype of each patient. So you know that if they're male or female from your EMR, you know their weight, you know their so their blood pressure, their pain score, basically the whole phenotype of that particular person. If they go to do a particular type of surgery, right? Then if that doctor sets up a prompt of reported outcome measures and starts collecting data, then you start realizing who's the best doctor in the area. And if you look at the reimbursements for a lot of these really good surgeons, right, that have low infection rates, et cetera, or that who put cats in. I mean, I've been in Scottsdale, I did residency here. I know who I want to do my surgery. So the whole point is that if they can start collecting data through these EMRs, setting up, patient reported outcome scores per physician, and if these physicians specialists who want to do cash-based models, then it would be very easy for a patient to make a decision where they should go and if they're going to pay cash. And sometimes the cash now, like, one of my best friends, a cardiologist, quadruple certified. We go to dinner all the time. He's like, I'm getting $650 for a cat. And I'm thinking to myself, like, okay, Medicare is Medicare. But like, if I needed a cat, I'm coming to you because I know that you're really good. And I pay you a couple grand. So the ambulatory surgery centers, especially for interventional cardiology, could go to a cash-based model. Could easily. Because the issue is the insurance reimbursements are lower and they can charge a little bit more with cash and become the surgery center as well, then it's very viable for specialists, very viable.
For sure. I'll look at it this way. Anytime the AHA lobbies or something that they do want to do, it's not good for us.
Right, what?
Anytime the AHA says, hey, you want to do something, it's not good for us.
American laws.
Yeah, American Health Association.
Okay.
So the cardiovascular.
I haven't. I was wondering who else was.
Oh, no, yeah. For us.
Okay.
So we're on the, we were on the.
I know what side you're on.
I actually wanted to add,
But so.
can I add?
A couple dozen goes, right? They were getting ASCs for CAS, I think coming back in 2024, that's what say. And so there are these hybrid OBL heart ASCs that are ready to do CAS, so it can be done like this. I mean, I remember having a cath lab in Oro Valley and getting complaints from university houses doing heart. I said, you know what? Your guys, the open heart team, are gowned and gloved and sterile. It's going to take 45 minutes for a simple lab team. And if we have a patient that goes bad or a table, but it's going to take 20 minutes to get down there on the ambulance. I bet we beat you down there before you get to have that patient. So the same thing, patient selection, you got to come in. Patient selection, that's what you do. And all day long, AHA can't stand it.
Yeah, you would go cash, you go up the door. And so, but except for like Medicare, but it's the bread and butter for cardiologists, a lot of people is Medicare. So, the DBCs who try to do a hybrid model suffer, but specialists could easily do a hybrid model, and I know that they're looking more and more into that.
Yeah.
That's what I was going to actually try to comment. Hi, sorry. I hope, can you hear me?
Yep, we can.
Oh, so about that information about collecting that data, insurance companies do collect that data and they do know the outcomes of surgeons and they in fact rank them and that's how you get your tier 1, tier 2 ranking. So I didn't know if the folks at the specialists out there know that. And I came to this information because, all of a sudden I started getting a lot of calls from MSOs and ultimately found out that they were trolling this insurance information and trying to find places with tier 1 surgeons or tier 1 providers with good outcomes. So, the question is, one, how to leverage that information when as a private practice surgical specialist, because I think we're kind of the last to see some of the difficulties that the other specialties or the other service lines we're experiencing now. I think it's kind of hard. So how do we actually leverage that information, and how do we become a hybrid model? Because, I think people have wrapped their brain around direct primary care, but for surgery and surgical specialists, they still hold tight to that insurance. Well, I have insurance, and that is like surgery is the disaster that they're thinking. So that's what they feel insurance is for. So how, what is the solution in kind of breaking that mold of thinking and maximizing our ability to have good outcomes?
Insurance companies are for the centers. Those are the marketing team for the hospitals and surgery centers. They're not the marketing team for the physician. There is a company out there that does all the prompts for you, and they can put a ticker symbol on your website to show you the outcome data. So it also builds up your, it also builds up you as a person, it's a little bit of a chest bump when you get the really good high scores. So that data that's being collected, it's used by the big systems to promote big systems. So all you need to do is privatize that information for yourself, for individual surgeons, and they can use it, because if you're a tier 1 hospital, how do you know that tier 1 hospital got the tier 1 status versus one doctor or another doctor? Because they don't really care. So if you have 3 surgeons and then one surgeon's the best, they still want you to go to that hospital. You might see the 2 bad surgeons, you don't need that one. So I think it's very, very, very important that doctors start owning their own data and owning their own outcomes.
Absolutely, and they keep data on both physicians and facilities.
For sure.
Yeah, and so you can go on there's whatever data, there's a data provider that hooks the reference-based pricing, and you go to their data and you look at the facility and you look at the doctor, and okay, this doctor's awesome, this facility's bad, from readmission to infections and yada yada. This doctor's great, he's works out of the same. They're great. I'll have him and we'll go there. But back to your point about you can ditch the code when you get to a cash model and it's purely free market. Yes, but you can't. You're not going to be able to ditch the codes, because there's got to be quantification of what services you're being delivered, and that's the way that payers do it. So you're going to have codes, and yes, you can charge more, and then they know that your charge of that code is better or worse. They take your quality score, multiply it times your price, and whatever factor that happens to be, and compare it to somebody else quality score and price, say it's a better deal or a worse deal. These payers have to have some sort of quantifiable measures of what is value versus what is not value.
But the
payer is the patient in a direct cash model,
right?
And he's there, but you're going to usually the payer is the employer. And usually they're looking across a broad spectrum of members and or employees, and they are working that in conjunction with the next level up, and it's the expensive case, and that's the stop most people. So you have eyes on this. Most people don't just show up and go, hey, I heard you guys are great. I need a angiogram. How much? So there's got to be a quantification there.
Yeah. Question to shift a little bit. There's the vast majority of physicians are in large entities at this point, right? They're hospitals, and it's kind of reported that they're not terribly happy. How are they keeping them, and what do you see would be something that will cause the shift of the migration away from then, where they would take a little bit more control of their own destiny?
Yeah, good question. So just in my experience, right, it's typically the physicians coming out of school for easier to pick the hire to bring on your payroll. And then also, this again, my experience was when some of the doctors got to the point when they're ready to retire, That's, hey, look about employment, you know, if you want to talk about it. And so those two right into the scale. I think, you know, back in the nineties, I recall I was with the HCA, and sorry, it is a long time ago, but we high-fived, right, when we sold our last position practice. We were celebrating not having any more employed positions. And when the pendulum, right, you were there, when the pendulum, you're the way again. So I just wonder, right now, you know, the reimbursement models are still in favor of the big hospitals. And when you bring a primary care physician on to employed by a hospital, my first hospital doctor, you know what, each one of my employed primary care on the clinics, 1 out of 10. That's profitable. And she was a go-getter. In the money, she was a go-getter. And the rest of them lost money, but on their clinic base, but it was the enterprise stuff, right? That the hospitals always looked at in terms of what those primary. I don't know where we're going to be in 5 years. Is it going to swing back the other way? I should go. So the stuff we're doing together, we're going to keep digging. I think, like I said, you know, 2 years ago, it was really different. And like again, just being at the Rosetta conference, the conversations about all the different activities going on, you know, PBM, direct contracting models with folks like claim on. We got capitalism in the mix now. You got PE looking at EBC, right, which is a huge deal. And then you know, Scott Haas coming in town, we're getting together, and all these different constituents we know, and how do we put together the next big move is bringing the fragmentation together. I think that's going to be powerful. And if we bring the separate pieces that we're all working on together, we're going to have some traction. At that point in time, you know, there's going to be power in numbers, and we might see some changes for the better. I don't know what it looks like. No idea. But I'm excited about it. It's pretty cool.
I think the answer to that question, I don't know what the numbers on this at all, but I probably find the answer to look at number and percentage of the residents that are being acquired by being hired by health systems, what that percentage is versus the current actual market. And practices, and then also the churn rate for those docs to maybe leave after a certain number of years. And start comparing, you probably figure out where we're going trajectory wise, right? But I think at the end of the day, it's going to take a lot of gut checks and asking these docs when they're in residence, okay, it's either golden handcuffs now, right, or it's going to be making a bigger revolution. And else to do that.
I agree with you. That's really good. That's a really good point. But that's what you're going to find out in the future as well is the management service organizations they're going to come out. So you have a lot of management service organizations right now for the insurance-based model, right? They look like this, right? But you know, you have desks, you have offices, you have building, you got all of that. But if you simplify the business model, right, to say, like, or just for example, the easiest, the most simplification of a business model for say primary care or procedures or even PT is like you have a corporation like GoDaddy up the street. We're going to hire you as a physician. You're going to go over there. You're going to take care of our employees, and if they have back pain, you got your little PT center. That's it. So what happens? You schedule, you see it sync. That's it. So the whole point is that as soon as the business model becomes KISS, keep it so simple and stupid that any doctor can open up a practice and just start practicing, then the model will shift. You can't shift into this model because there's too many layers within the screen. So once somebody comes out with a management service organization or even DTC that says, look, you can open up a practice with this little book right here, and this is how you open it up, this is how you market, this is how you get people. You only need these doctors. They don't realize that 500 very much to get. Like, sure, you get 500 people, it's not that hard. It's the same, yeah, let's say about you're right. It's not that hard, and then you're set for life, basically.
And so, you know, that's where doing the bundles of scripts, right? So I got to thank folks there, for during Glenn. General bundle, and Tish got it going. You know, they never asked for insurance card, because that just costs a big old mess. You guys trying to money back from insurance company. You kidding me? Never happened. And then, you know, we got, I mean, a number of different independents, got Pop Canyon and Season, those guys are awesome. They're independents, know they left the bigs, Envision them, a whole bunch. They're doing well. Eric Eifler, right? He's doing great. And there's kind of, all the big screen. So there's no space. It's just not a big.
Ortho AZ, Doug Van. What was the name of, what was the name? He said, oh.
Oh, he is. All right. Hey, Dr. Bailey, we got talking. Sure. Yeah, well, boy, we got the other. Yeah, what there is on this. Yeah.
Dr. Brown, Dr. Van on the tunnel.
Okay. Cool.
Well, it's getting late for me, so I got kids to get home too.
That was very much, it really, very gracious to us.
But thank you so much.
Appreciate it very much.
So we will be having a meeting every 2 months, and the next one is on the schedule. I think it's already on the website.
Encourage everybody to go to the website. There's some information, there's clips, there's some of our past presenters that we've had there. But also just to be involved in the Free Market Medical Association, sign up, and you know, it's helpful to see who is actually kicking tires, who's actually interested in doing something. So can't encourage everybody enough to get involved.
Yeah, and if you sign up, then you're officially part of the team. And so, you know, you might wonder what's the benefits of actually being an FMMA member. It means that you're committed, and that you're part of the movement. And it also help us to drive further resources in getting this moving. So,
And you get the password to Steve.
and you get the password.
And you get cell numbers and email addresses too.
There you go.
Yeah. But thanks, everybody.
Thanks everyone for on the call.
Thanks, guys.
Thank you all.
Thank you. Thank you.
But I got the one side, I damped, and I think my hand is like pressing it around. So I had X-rays, and I got an airline fracture right here on the bottom. I'm riding motorcycle. Went down. No, I was going, I started going over. It goes down to some. So that X-ray, the artist is like that. Well, yeah, lots of purple. Give a little love. Put all this. So it's like 140 on right, and then everybody going in.
I wouldn't worry about it at night. It's more when you get out and you go late.
I know. And once you have that, it costs us Oh, wow, okay. Yeah. I really backed that out. Yeah. What you do, I guess the business because PR is, you know, and so yeah, we're gonna try on here. You have a bunch. It's not critical. Because these guys that they were going there, you pay them for this up, they give them the space. First responder office, you know, break room or whatever. And hey, fine here, by the way, here you go. It's always talking food, it's always talking video. I don't well, I just talked to my it's nice. Sierra, well, I'm really. Racing, and so Laura was
I gotta.
Literally. Style of. You got to score in score race. Score race is ready. Go. Cross finish line. Bar is. So when they do bomb, they pull out the bomb, and they so it's way better. So it's. Oh, that's important. When we so we always get raise the bar and then those guys all the time. So we've seen that every year. Think about how the your family's going to go down. I just want to strong. Military service, cages and suspension and seats. And we went very slow. And then, we get slow. No, we get a little easier. It serves and stuff. You going around. You will send them to get out there.